You ready? Okay, we'll call the third meeting of the statewide substance use response treatment and recovery subcommittee to order. Crystal, please take roll. Or is it Kelly? I'm sorry, Kelly.
I can take roll.
Okay.
Crystal, do you want to share this screen of the PowerPoint and I can go ahead and take roll?
Okay, that's great. That's actually what I was kind of trying to maneuver.
Assemblywoman Claire Thomas.
Present.
Chelsea Cheatham. Dr. Leslie Dixon.
Here.
Jeffrey Iverson. Lisa Lee.
Present.
Steve Shell.
Here.
Thank you. Madam Chair, we have a quorum.
Thank you, Kelly. All right, we'll go to agenda item number 2, public comment. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. And are there anyone on the phones that would like to make public comment?
I'm not seeing anyone. If you are only joined by phone and would like to make public comment, please speak up now and the chair will recognize you. I don't hear anybody, so I think we can move to those who are joined on Zoom.
Okay, anyone on Zoom? Has anyone raised their hand, Crystal?
I have not seen any raised hands yet. There's still a chance to do so before we close public comment, so I'm scrolling through on my screen. And I do not see any raised hands.
Okay. All right, then we will move to agenda, excuse me, we'll move to agenda item number 3, review and approve minutes from May 16th, 2022 subcommittee meeting. Members, please review the minutes and note any changes or corrections. And,
Yeah, this is Dr. Dixon here. Most of the minutes were from my presentation.
correct.
And there's a lot, there are little inaccuracies throughout. And of course, and I would be happy to edit it to get it to be a little more accurate. If you all, whoever does the prepares the minutes, will send it to me in Word rather than PDF.
Yes, I can do that.
Okay, so you are saying that there were inaccuracies in your presentation?
In the minutes of my presentation.
I see.
Yeah.
Okay. So
Some are, none are hugely important, but a couple of them had like a positive when it should have been a negative or something
see.
like that, you know.
I see. So we can table the approval of the minutes if I'm correct. Am I correct? We can table this to our next meeting?
Rosalie, can you just confirm that we could, and if we do that, do we need a motion in order to table the minutes for approval at a subsequent meeting?
I think
You don't need a motion. Let me just check on the calendar real quick how many days we are since that meeting. So it was May
16th.
Minutes need to be approved within 45 days. So I just wanted, well, I guess we may already be past. I would say you could give a conditional approval based with corrections. Might be the best to do that since it's just corrections to the presentation. Am I correct? That you're
That's
looking for?
that's all I'm remarking on, yes.
And I think Lisa Lee may have other corrections.
Then I would, at this point, I think we're beyond the 45, so you probably could just make sure that these minutes as they are right now, if anybody requests them, are available.
They are on the public website
Okay,
in draft form.
that's fine. Yeah, and just, I don't know, what might be better is to say, approve these is still in draft form, but as there, so they're somewhat approved, but noting that you will make some corrections to in the future and kind of reapprove them at the time. I think
Okay.
that would be a little bit better since we're running up on that timeline.
Okay, so I'm asking for a motion to approve the minutes for May 16th,
I think,
2022 in draft form.
sorry, Chair Thomas, we do need to get Lisa Lee if she has corrections.
Oh,
So if
okay,
you
I
want
didn't know that she
to
was
recognize
on.
Lisa, she can speak next.
Okay, Chair recognizes Lisa Lee.
Thank you, Madam Chair. Wanted to point out on page 3 of the minutes for May 16th, 2022, it mentions the Harris Act, but that should be changed to the Harrison Act of 1914.
Okay,
Thank you.
and that was it?
One
Any-
correction noted, but like there's a lot of little things in there. And that I really think would be better fixed than leave the way they are.
Okay, so as we were stating before, we will approve the draft form of the May 16th, 2022, forthcoming with corrections to the minutes. If
I'll
we
move.
could have a motion for that, is that okay, Rosalie?
Yes,
Okay,
All right, Dr. Dixon, I'll move what you just said.
thank you. Do I have a second?
Lisa Lee, for the record, I'll second that motion.
All in favor?
Aye.
Aye.
Any opposed? Any abstentions? Okay, the motion passes for the minutes in draft form to be approved for the May 16, 2022. Okay, thank you so much. Glad Rosalie was on this call. Okay, we'll go to agenda item number 4, presentations from subject matter experts. Today we will hear from Charfrost, Nevada PP, who brings experience navigating systems and advocating for treatment systems for youth as a parent, and from Christina Chris Thomas, owner, Living Free Souls, and chair, Southern Nevada Veterans Advocacy Council, about her lived experience navigating substance use treatment systems. Based on discussion at the April meeting, we have Michelle Patton with the Center for Applied Substance Use Technology, CATSIT, which is contracted with the state to provide certification reviews. Michelle is available to answer questions about gaps or resource needs across providers in the state. First, we will hear from Char.
Thank you, Chair Thomas. My name is Char Frost, and I am the Statewide Family Network Director for Nevada PEP. Nevada PEP serves families of children with disabilities, including those with mental health needs. And we do recognize the intersectionality between disabilities and mental health, and of course, mental health with substance use. My lived experience is that my oldest was shared with me much later that he started using substances in the 4th grade in elementary school. This was not something obviously that I was anticipating in that early in life, but and it led to kind of a snowball effect where ultimately he started he at some point upgraded and started doing methamphetamines, and unfortunately or fortunately, depending on the way you look at it, I look at it as a fortunate matter. He did in fact contract HIV and is currently clean and sober because his desire to live was greater than his desire to continue utilizing meth. Having said all of that, when he was in high school, we did look for substance use providers. And what we found was there were very few providers within Nevada who would work with youth. And we still, I work with families every day. This is still a concern for families who obviously don't want to send their children out of state if they don't have to. The other issue is that when we do when they do treat substance use, when we are able to find treatment, it seems like there's little to do. It's more about the substance use. It's either or. They're treating the substance use, but they're not going to treat the mental health. That may be the underlying need. Because I firmly believe that my son was using to self-medicate for his, and he has multiple diagnoses. So some of the other issues are that youth are not little adults. We should not be treating them as though they are. And families need to be involved in the treatment. We need to know how to support our youth, both during treatment and when they come and when, and after that treatment, those post-treatment and how to keep them healthy and whole and, hopefully off substances. And then there's always this issue. Families often feel judged when bringing their youth, whether it's for mental health or substance use. So approaching families from a strengths-based perspective is important, and it tends to foster trust with the provider, but it also leads to better long-term outcomes because families are more likely to stay engaged in treatment. And then also that recognition that families are really scared when their youth is not doing well. And being non-judgmental is really, it really goes back to that being strengths-based. All families have strengths, just like all families have weaknesses, but we can build upon those strengths. And so some of the recommendations that I would put forward to this group and others would be to create an incentive to encourage dual licensure for mental health and substance use, whether that's higher Medicaid reimbursement, an increased number of sessions in addition to family therapy, because I think family therapy is one of those critical pieces. Our kids don't operate in a vacuum. They don't grow up in a vacuum. The whole family system is impacted, whether it's mental health and or substance use. So we really do need to strengthen the entire family. I would also say training drug and alcohol counselors in system of care philosophy, core values, and guiding principles. System of care, we do currently have a system of care grant. It is really focused on mental health. But again, I believe that substance use is very much, that intersectionality exists, and we need to recognize that and elevate that message. Also, incentives to bring youth-focused workforce to Nevada, whether that's via student loan forgiveness or just decreasing some of those barriers to licensure. And I know this has been, we've had these discussions at the legislature over the years, but there needs to be more focus on that, especially coming out of COVID, where we know that, you know, the Surgeon General has already told us to expect some pretty significant impacts, especially for youth, which could lead also to more utilization of substances. And increased training opportunities for the workforce and best practice and evidence-based treatments and programs for those who are serving the population, and ensuring a continuum of services, including a robust array of community-based services specifically designed to meet the needs of youth and their families. Families really need options. No one treatment, whether it's for mental health or substance use, fits every single family, just like it doesn't fit every single individual. So having as many of those evidence-based practices and best practices in the state, and again, the workforce that is, you know, has that training to work with youth, would be very helpful to expanding options for families and their children. And that's all I have.
Well, thank you, I'm sorry, I thought it was muted. Thank you, Char. You know, great presentation, especially with the lived experience. You know, I have a question. Your son, how is he doing?
My son is doing very well. He's, you know, he's taking all of his medication, is at a 0 viral load, and is healthier than he's ever been. And also is actively engaged with his own mental health services in Las Vegas. I mean, we've lived here almost his entire life. So, so we, you know, we all, I mean, this is a household filled with mental health, but we are all doing well and doing what we need to do to stay healthy and whole. So,
Well, thank you, Char. I'll open it up to the committee. Any other questions for Char? Ms. Frost? Any questions? Okay, if no questions, then we'll move to Christina Thomas. And at the end of her presentation, we'll open it up again to questions. Okay, Chris, please, you have the floor.
Thank you so much, Madam. I appreciate everyone here, and I just cannot thank everyone. I'm sure, thank you so much as the actual family member, because this is why a part of my presentation is to talk about the actual family support. I know that I was introduced as the owner of Living Free Souls. I am a mind-body spiritual practitioner that works with veterans and individuals in trauma and different holistic modalities. And as a peer-to-peer, vet-to-vet, I am medically retired Air Force. I overcame a mind-body situation that was very complicated. If you give me just a quick next, and I gotta leave the other one off so I don't get feedback. Hopefully that'll fix the feedback. Okay, there we go. So I'm coming from substance prevention. I had to write this down. It was a lot because it's not just my story. I take in a lot from being the chair of Southern Nevada's Veterans Advocacy Council. As you know, we work with LVR3, PRRC, and all the nonprofits of 70 different folks. So I always want to make 70 different organizations and affiliations. So I always want to make reference as in a group itinerary in working towards what I see a solution and a commonality and theme. So I'm coming from the theme of long-term patients. Now, this is someone, I know we know statistically how high it is with chronic pain and patients, but there is a substance use problem that we are missing. I am actually a patient. I am over 7 years on extremely high opioids, morphines. I was a teen young adult alcoholic. I'm a kidnap and rape survivor of military sexual trauma. And I am a suicide survivor multiple times over, and 2 of those were chemically induced due to pharmaceuticals. So I'm coming to express this to you. I am actually a rare patient that is being studied by UCLA and the Cleveland Clinic for Mind, Body, and Mental Health and Physical Health Connections. So the idea of what I have uncovered through this journey has not just been so much as a gap, it's more as there's no information. There's not enough patients that understand the terminology and the technicalities that's happening and the awareness to be able to express where those gaps and little fall-ins happen for me and for my assessment. So long-term chronic terminal patients under pharmaceutical medication classifications that range from tier 1 and all the way up and down with other medications and chemical consumption exposures causes ingredients of that person's biochemistry that mimics that of addictive neurological neurotransfer overload. So I know that this is going to sound a lot of technicalities, but the reason I'm saying that is because we're talking pharmaceuticals with substances. So what happens neurologically and psychologically, you're dealing with medications that are not only neurological long-term medications, but they are also used as psychological medications. And when you're a veteran that has multiple things going on, you are on multiple medications that will have pharmacokinetics, and they will create side effects and chemical compositions to create addictive behaviors. These result in addictive behaviors with less harmful substances combined with your regular consumptions of life or any other self-medications that you would need to do. That could include plant medicine, herbal medicine of any form. With these effects, you see someone on opioids, your basic substance that the community sees is your crack, methamphetamines, different things of that matter. But I want to talk about other substances. We're talking pharmaceutical, steroid infusions, chemotherapies mixed with neurological medications and pain management medications that are not red tape. With that, some of these effects on the mental health takes a toll on the chemical balance of that person, and they would experience something known as psychosis. What we know in street terms to know it as tweaking, geeking, out there, on one, she crazy, all of that. These are under the umbrella of behavioral health instabilities to the extremes as psychosis, suicidal ideations, homicidal ideations, and more. These are created for someone that is in long-term care undergoing different substances to create a stabilized homeostasis balance of that person's lifestyle. You can create these extremes to make a red tape effect by just adding your specialty care medications mixed in with anything else outside of that specialty care. The pharmaceutical overload then requires the person to increase their levels. As you know, your neurons in one way and that way, that pathway is for those chemicals to communicate. When they're communicating, they have to receive only that much information. So if it's already overloaded and this isn't working due to physiological problems, that person is going to have behavioral instabilities and psychosis that can create long-term effects into families as well as the communities and create liabilities for that person. With that, at high levels, patients are taking forms of substances so that they can have that. We know this as self-medicating, but as someone that has been in long-term care, I don't see this as self-medicating. I see this as someone trying to self-regulate or escape because they lack the tools or understanding of what's happening in their body. So you're labeling it as a substance abuse when truly it's a substance use for them to understand how to balance. They're not given the actual tools and skills. When you hand out a prognosis, you better be handing out an ambassador peer support, recovery specialist, or someone to help you understand and navigate the journey of long-term care. You only see those things in hospice care because that's only time that funding allows that expense for extra care. But there is an influx in the community as well as our nation in the rise of chronic patients. Pain is not just one of those. We're talking whole health. Well, so what do you do when you have to take these medications? I'm going to explain from my living experience. I have had over 50 surgeries and procedures. I was on over 40 pills a day just to stay alive. My liver burnt up. I burnt my brain up. I created seizures and epilepsy. I had psychosis, liability issues of violence. These were all induced by increased high level of substances. So that, and the reason why is because I chose not to take pain medication so that they have to create another pharmaceutical cocktail to navigate that person, which therefore can create a chemical imbalance in that person's psyche and a chemical imbalance in that person's immune system, therefore exacerbating the pain, having them to take more medications and go out of the way to find different things. Well, something does occur once there is an overload, and it's rare. Now, I am medication resistant. Now, I got off of opioids and all of that by going to college and being certified through medical cannabis and plant medicine and Eastern understanding. So I went to Pacific College of Health and Science. I did different modalities, and I took the route necessary to dive in for my own personal health. People don't have that luxury and time and expense to go back to school to learn what is needed, and they're sick. They need to heal. Putting more information in is stressing them, creating more chemistry and more problems in their body, and that further exacerbates them. Now that I am medication resistant and only have a chemotherapy form as well as medical cannabis and herbal medicine, as well as natural infusions of macro and micronutrients, that is all I can do. I no longer can take those. So from that, I actually came out of it and began to do the studies with other neuroscience and psychologists and physiological doctors. Well, what we have understood was we have to provide more evidence-based therapies. I went through 10 years of evidence-based therapies by the most world-renowned, amazing Veterans Administration whole health pilot program out of Salt Lake City. That was working on the mind and the body to include the substance use constantly being put into the patient to maintain so that they did not go into addictive behaviors. That person is undergoing their life being destroyed. They're not okay. It's situational. It doesn't mean that they have a diagnosis of depression and anxiety. It means they're a human being and they have feelings. So we need more natural Eastern medicine prevention care that is covered under insurance. I spend over $2,000 in secondary health care alone to stay surviving, because I can't take the medication that is only prescribed by the VA and Medicare. I can't take that medication. Now, what if I was not capable? And now that I can't do my businesses because I had to pull back, I had massive seizures, and now I'm under specialty care all the way. What am I to do if my insurance can't cover because my substance overload does not allow me to take the medication and it causes suicidal ideations? So if it's not covered, then what do you do for those patients? I'm that millennial that said I wanted to retire at 40, so I set myself up and I'm medically retired. That is a rare situation, very rare. I can afford to take care of myself for only so much. If I have to incur more cost of travel and finding this and that, then what is that patient going to do other than go out and self-medicate to create a chemical composition to give them the relief that they were getting from the pharmaceuticals? That's all that they are trying to do. So we need more recovery peer support sponsors. We had those bills that were passed, and we do know that they are building those up with recovery specialists and that being covered under insurance. family ambassadors. There is a program nationally known as REACH, REACH. That is for long-term patients that actually know they are going through psychosis. You want to give them the tools to get through it. By God, if we can't get them what they need, give them the tools so that they can learn how to take care of themselves. I want to be able to say that we have more outreach with the city and the state to bring these awarenesses up so that it is not stigmatized in the ideals of it's just methamphetamines, crack, this substance, that substance, alcoholism. It's bigger than that. That's why we have a chronic pain epidemic. So it takes up to a year for you all to understand neurologically what this is. This is something for us all to grow in self-development. 1 minute of anger takes 6 hours for your immune system to recover. So imagine someone that is trying to heal that has to deal with this and their immune system is under attack and they can't get their health care situated. So not only that, it takes up to over a year for the body to reach normal homeostasis after substance overload. So constant tools will be needed to help prevent the relapse that you see. Families need to get that through those national programs like I talked about and evidence-based things such as cognitive behavior therapy, processing therapy, so that you don't see a rip apart of families that's going to cause an influx on your social economic situation in the community that's already strained. That's what we're seeing, that's what we're facing, and that's what I've lived through. And so I bring that expertise to you, and I am open to any and every question. The specialty care and medications I'm referring to, I am on Rituxan every 3 months, Sodramedrol, 1,000 milligrams of steroids will cause you to have psychosis for 2 days straight. You will not sleep, not to mention the other neurological medications on top of that being crossed over into psychological medications used for both modalities. So you have mental health, physical health, neurological health, rheumatological health, urological health, and all of that. I'm one person having 5 different specialties with pharmaceuticals being prescribed. What do? We need to have more case managers to make sure that this doesn't happen. We will all have flesh to deteriorate, so we will all experience at some point the need to have health care. So we have that responsibility right now to put the right people in place so that we don't have another epidemic that is not opioids, rather just substances. Okay. Open to the floor.
Thank you, Christina Thomas. Excellent presentation. Okay, I'll open up questions. Please, members, do we have any questions for Ms. Thomas?
I see Lisa has raised her hand.
Chair recognizes Lisa Lee.
Thank you, Madam Chair. Thank you, Christina, for that excellent presentation. I don't know if you could see me, but I was in agreement as a person in long-term recovery. I totally hear what you're saying, and also validate what you're saying. I also agree that people are just looking for a way to regulate and find some peace, and substances bring that. Unfortunately, you know, getting on that hamster wheel makes it really difficult to ever get off. And I too believe in a holistic approach that incorporates mind, body, spirit, all of it. For me, and I just want to state on record that, you know, what really solidified my ability for my brain to heal, because it took about 3 years for me, for my cognitive to come back and really feel kind of normal, whatever that looks like for me, and find that homeostasis. And I did see an alternative medical provider. I used some neurotransmitter chemicals called NeuroReplete and CysReplete that were really, really helpful for my brain to heal, as well as going to drum circles and fire spinning and I mean, those were the tools for my early recovery that helped me do it this time. And I've got 20 years. So I just encourage multiple pathways and for people to really find what helps. And especially for people who have experienced sexual trauma, I feel it's really super important that we address all of that trauma that we carry around in our bodies, that traditional modalities do not. They do not deal with the things, the scars that we carry around. And I feel like that is essential to whole person wellness. And so I just commend you for everything you said today, because I think it's important to embrace ways and facilitate payment methods for people who are seeking options outside of the, traditional allopathic Western medicine. Thank you.
Thank you, Ms. Lee. Any additional questions or comments for Ms. Thomas? Okay, I don't see anyone. Crystal, do you see anyone with a hand raised?
No.
Okay, all right. Thank you, Christina, Ms. Thomas. This was very informative. I do have a question though. When you mentioned veterans and cannabis, does the VA allow for, to prescribe cannabis for their veterans under care?
No, and that's, I'm glad you asked me that question. Thank you. So we do know the VA Research Act, the War Act, we do know the Mission Act. We do know that we allow them to be able to say, doctor, I am a medical cannabis patient that is in a legalized state.
I'm sorry, Christina. There's like feedback and I'm not getting.
Can you hear me?
Not as clear as before.
Can you hear me now?
Yes, better.
Okay, I'll lean in. So we know the VA Research Act, the War Act, and the Mission Act. All of those impact veterans and cannabis care. Now, we are a legalized state that we are one of the top states in the nation for veterans. However, when we became medical, we got it off of veterans, the VA Research Act, veteran care, patient care. However, we did not build a medical program up to have a sufficient amount of patients in the medical program. So even though we have it in there that you can get a medical card for medical cannabis, veterans have to choose on whether they want to keep their concealed carrier. They have to choose, it is not beneficial to veterans. At the end of the day, you now are not getting medical license issued to dispensaries so that they can't get the medical cannabis discount with the veteran discount to afford and sustain their care. So this is something I've taken to the cannabis industry because the VA cannot move. And even when they do, they have a uptick of education that they have to go through. They got to go back to get CEUs for cannabis. Cannabis is medicine. It does not correlate all with pharmacokinetics. That's why it's a tiptoe right now, because you have every state doing it different. Every state has different methods of use that they allow or they don't allow. Every state has some form of legality in the form of cannabis. Now, when you say, give you example, I can't take that medication. I'm a medical cannabis patient. I've been in the medical cannabis program since 2015. I moved here in hopes that I could find different modalities legally. So when I got here, I went to my provider and I let my provider know I take medical cannabis. I am not, because I'm in recovery, I do not take substances of opioids or addictive behaviors. Now, at the beginning, you will hear stories of veterans being told they cannot take cannabis or they had to choose. That was and that did happen. people were being told in the VA they had to choose on which one that they had to. Well, they finished with the bill 2 years ago, 2020, and they said, we will not force you to choose on which one. They can't do that to you. And they can't tell you or advise you not to. All they can do is give you information about the care of cannabis. So that means for me to have my actual method of use, and this is scientific, you know, this is not some stigmatized stoner, I just need to do it for whatever, everybody to each their own. I have to have a method of use of being able to drink the juice, to take the RSO, to have it at the certain terpene and chemovar levels for my conditions. Now, with that being said, I have to be a mad scientist. I work with a cannabis doctor. I figured that out, and I actually have cultivations. But I can give all this information to them, but they are not going to take that information in other than she's a medical cannabis patient. I can't give her any pharmaceuticals of addictive, like they're not going to prescribe me if I go in at the VA morphine. They're not going to give me a benzodiazepine or something like that, because on my record, I'm a medical cannabis patient. And so with that being said, I have incurred a lot of hardship being a medical cannabis patient, going to the ER. Oh, you're a medical oh, well, that's what's wrong with you. The assumption, the stigma. And I have to educate the doctor and tell him to go back to college, because I don't think you understand this plant. And it is actually the only thing that's working for me, that's keeping me alive, is cannabis and chemotherapy. And so the problem lies in not having a veteran program or a medical program. So at UCLA, they said, Christina, I want to put you into the cannabis program, but oh, you don't have a cannabis program in Nevada, so I can't put you in it. So now I'm a veteran that cannot even get her care because we failed here in the cannabis regulation. So I'm not going to sell my house and move to LA. And I have to be there every 2 to 3 weeks on this. And I have to pay over $2,000 a month for just my cannabis, because that's my only medicine that's treating all of my list of prognoses. So veterans literally, because of the taxation for the medical and everything, veterans literally for 1/8 are spending, for the proper amount, are spending upward from $40 to $60. That does not last but maybe a day or two. The RSO, at the rate and the price of that, they cannot sustain that for everyday use. So they end up having to do substance abuse, getting the wrong thing that could cause psychosis, because there are chemicals. This is a chemical. People are not aware that just because people say, oh, it's, you know, if it's CBD, no, cannabis is cannabis, whether it's hemp or marijuana. The difference is one chemical in the THC. Cannabis is cannabis, period. And so having that understanding and having UCLA with their hands tied themselves, talking to the industry here, the compliance board here, I have tried to help them understand this is medical malpractice. This is a medical plant. This is a medical, that's why they were able to stay up during the pandemic. It is considered medical. Well, then how are you not medically taking care of me? And there is no compassion care programs, unlike California, Oregon, and all the other places that have built it up. There has been no one, because we didn't build up the program.
Thank you, Christina. I really do appreciate you coming forth and being transparent with our subcommittee members. Thank you again. And next we will hear from Michelle Patton from the Center for Applied Substance Use Technologies. Is Michelle on?
Yes, thank you, Madam Chair. Michelle Patton, for the record, with the Center for the Application of Substance Abuse Technologies, much easier to just say CASAT. We are at the University of Nevada in Reno, and we are contracted with the state to provide their substance use prevention and treatment certification services. So we were asked, first, let me just say thank you for the great information today. It is wonderful to hear. We were asked to speak a little bit today about the needs that we see or hear treatment providers talk about when we are on site doing their certification services. So certification services are based on NAC, Nevada Administrative Code 458, and division criteria. And so that's the authority under which we conduct those services. I want to just talk a little bit. Our team kind of came together and just talked about different things that we hear and then see, and then other areas that we are partnering with the state to work on, and things that we might hear sometimes from licensing boards that are needs out there. So probably the biggest thing that came back was just the workforce development is probably the biggest challenge currently. Hiring qualified staff in the current environment is pretty challenging, specifically for SAPTA certified providers, which tend to be either your SAPTA funded providers or Medicaid reimbursement providers. And the reason for that is because they're competing with a lot of telehealth companies and for-profit companies, and they're just not able to pay quite as well. So that has been a pretty significant challenge that we see out there. Where we see it impacting most is that they might be able to have counselors that are licensed or certified in order to provide substance use services, but possibly not mental health services. And so back in 2014, we partnered with the state to bring a process in that was called DDCAT, which is Dual Diagnosis Capability and Addiction Treatment. SAPTA offers a co-occurring endorsement, and the goal with that project was to get all SAPTA funded and Medicaid providers that get reimbursed through a 17-215 model to have a co-occurring endorsement. Obviously, the goal with that would have those folks be more towards the enhanced side of the spectrum rather than the capable side of the spectrum. Whereas capable, they're doing more screening and they have to do referral if they have clients that have a substance use and also a mental health or a co-occurring disorder that they're dealing with. And then they're having to coordinate care, which just tends to be really honestly more bumpy for the client. It is more work for the agencies as well, but the real individuals that struggle with that is the clients having to see multiple providers, and it can just get very long and tiring to the point where they either are trying to self-regulate or they're just not going to get they're not going to get treatment for one thing or the other, one issue that they're dealing with or the other. So one of the goals that we have is to try to, gently nudge folks to find ways to incentivize their current staff if they could enhance their license in order to treat a co-occurring client. And so the other part that there probably are some training things that could go on, or even the disciplines at school where if they learned a little bit more in a co-occurring model, but if we might have different, if you're a social worker or if you go to school for MFT counseling, whatever it may be, you kind of have your idea on the front end what it is maybe that you want to do, and then folks kind of just run in that direction. I've heard a little bit today talking about a continuum of care. We do certify a continuum of care from prevention services through early interventions, outpatient, residential services, withdrawal management or detoxification services, transitional housing services, and we are in the process of adding currently recovery housing services, which transitional housing and recovery housing, those definitely are areas that are gaps. And the part of the reason which you guys have all kind of spoke to today is if there's not a reimbursement method for that, then it's very expensive to do. So those are things that the state also is working on and trying to find ways to reimburse that. Of course, the rural areas, rural frontier areas, it's always challenging to get staff out there that can meet the needs of the individual citizens there. So that's another area. We work with them to try to utilize more telehealth. Sometimes that works well. Sometimes even internet situations can make that a little bit challenging. So again, we certify, there's over 175 agencies throughout the state within the continuum from prevention all the way through treatment that we certify. And those continue to grow. I think I probably have 12 right now going through the initial application process to be certified. We do also typically see that that adolescent services related to residential needs, that's always been a gap. And again, if they can build that into their continuum with adult services, not housing them together or anything like that, but if they also can have a mechanism where they can be utilizing adult services as well, then that seems like it isn't so costly. But that the adolescent aspect that Ms. Foster talked about at the beginning is a need as well. So that's really all I have. Does anyone have any questions for me?
Thank you, Ms. Patterson. Any questions from our subcommittee members?
Dr.
Okay.
Dixon, I just have one little question. I didn't quite catch her name. Who was speaking?
This is Michelle Patton, Dr. Dixon. I'm with CASAT.
Michelle, let me look for you on the pictures here. Michelle
Well,
Patton.
you might,
But
yes.
I got
And
you.
Okay, thank you.
Thanks.
Okay.
Thank you, Madam Chair.
You are welcome. Thank you for the presentation. I appreciate your coming forward and speaking on this very important issue. Okay. So I want to thank all of our guests that came on today to presenters to today that spoke, and we do appreciate you. And I am excited about some of the processes that I heard. I'm learning a lot. I'm a novice in all of this, and I do appreciate the feedback that I'm hearing. Okay, so right now we'll move to review. For agenda item number 5, review process for prioritizing recommendations and upcoming meetings. So let's get into it. It's pretty entailed. I want our subcommittee to look at our next slide, the timeline and process. At today's meeting, we're going to discuss the priorities that you ranked prior to the June SURG meeting. In August, we will hear from subject matter experts. The subcommittee can also review additional information impacting recommendations, such as any that may require a BDR, those that have a funding source, and those that do not. And recommendations include in the ACRN report. Also in August, meetings between members of different subcommittees may be held to review shared recommendations and revise recommendations as necessary. Discussions of how strategies can be combined, refined, or expanded will occur in the subcommittee's August and September meetings. This will ensure that the annual report includes recommendations that are significantly specific and actionable. Okay, so with that, any questions for agenda number 5? I want to make sure everybody understood that. Okay, so we'll move on to agenda number 6, subcommittee recommendations and preliminary prioritization. Okay, weighted recommendations were presented in June. We will review them briefly and would like to get additional input from the group. So as we review, questions or considerations include, does anyone have additional context to add related to any of the recommendations? Are there any questions about the recommendations? Does anyone have refinements to the recommendations? And what are we missing?
Madam
So
Chair, for
the-
the record, Kelly Marshall, I just put those questions in the chat for the members to see. And I see that Ms. Lee has her hand up.
All right, thank you. And Chair recognizes Lisa Lee.
Thank you, Madam Chair. Lisa Lee for the record. I do have a question regarding, and I'm not sure if anyone is on that could answer this question. But I have a question regarding the use and promotion of telehealth for medications for opioid use disorder. One barrier, and I'm not sure, like I'd have to do a bit of research to see if this is still the case, but peer recovery support services were not covered under telehealth in the Medicaid billing manual. And so I see that as like truly a barrier that programs are continue to have dependence on grant funding to be able to provide telehealth peer services. And so if there are policy wonks on the call today that could help in ensuring that everyone in Nevada, regardless of where they live, has access to peer recovery support services through telehealth, and that is a billable service, that would be fantastic. I know that that historically was a barrier when we were implementing under the IOTRC into rural regions. And although we did have grant funding at that time, the long goal was to be able to transition from grant funding to Medicaid. And that was a barrier. So if anybody can let me know if that's still the case with the Medicaid billing manual, or if there are, it probably still is because it takes a really long time to change those things. But if we could possibly prioritize that so we have recovery support services available to folks, that would be fantastic. Thank you.
Thank you, Lisa. Anyone from staff, do we know whether or not Dr. Woodard or Dr. Capuro can answer that question for Ms. Lee?
We've been in communication with DHCFP for this committee. So one of the questions we have later is if you want a specific presentation from them, but we can certainly ask individual questions rather than do a presentation, or we can do both. So we will note Ms. Lee's question and we can pass that on and come back at the next meeting with an answer.
Okay, that would be good. Or we can, like you suggested, a presentation too would be good for the committee, I think. Okay. Any additional questions? Okay, so we'll move on. So I guess that that answered the questions for discussion. Does anyone else have any additional context to add? So I didn't see any hands raised or anything like that, so we'll press on. So the weighted recommendations is next. Please look at that slide. And other recommendations are listed here around workforce, addressing children and youth treatment and recovery services, and promoting parity in behavioral health coverage using the hub and spoke model. So any questions for discussion? Does anyone have any additional context to add related to any of the recommendations on the previous slide? Are there any questions about the recommendations? Does anyone have refinements to the recommendations? Anyone, is there anything that we see that's missing? And would anyone like to elevate any of these to the final five? Okay, all right, with that, we'll move on to the next slide, please. On this slide, you see recommendations again related to workforce and strengthening the treatment and recovery support for youth, including those in child welfare system, in the child welfare system. Okay, does anyone have additional context to add related to any of the recommendations on this slide? Are there any questions about the recommendations? And again, does anyone, okay, Dr. Dixon. Chair
The only
recognizes.
thing I would say is that it's unfortunate the bottom one here, consider radical changes to recruitment, retention, and compensation of state frontline health workers is at the bottom of the list. I mean, if we don't solve this problem, then a lot of the other issues aren't going to get solved at all. So I think it should be rated a little higher.
All right, so you would like to move that up to a potential final five?
Well, maybe in this, the other, maybe number 6, move it up below the 5 and above the other 5. The
Okay.
first 5, but between the first 5 and the second 5. That would be my, but I mean, we all voted. I'm not, this may be, but I'm just saying that we are not able, at least in terms of my specialty, psychiatry, we are having a terrible time recruiting and retaining state psychiatrists because the compensation is so far behind the state and the national levels. I don't whether I can't speak for any other profession, but well, except psychology, they've been saying the same thing for years too.
All right, so we will, I guess we can, talk with the members that are still on here. My personal, I would like to see it within the next final 5 because, as I've spoken, I believe passionately, I believe that our children are, it's necessary for us to invest in our children. And the only way we can do that is to make them a priority. So I am in favor of moving it up.
Chair Thomas, Lisa Lee has her hand up.
Chair recognizes Lisa Lee.
Thank you, Madam Chair. Lisa Lee for the record. I am in agreement with Dr. Dixon. However, this is really vague. It doesn't identify any specific strategies on how to get there. Like, what do radical changes mean? Does that mean reciprocity? Does that mean, assisting our board of examiners or certification boards in the state, providing financial assistance so that they can have the staff necessary to offer reciprocity and to recruit and retain? I think this is essential to health equity. We do not have a lot of diversity in our workforce that reflects the diversity of our state. So I would add that we also need to consider diversity and inclusion in our recruitment and retention. But I would also argue that it needs to be specific strategies, because radical changes to me might not mean the same across the continuum. So what exactly do we mean? Do we mean reciprocity? Do we mean funding our certification and licensing boards? How does this look with practical application and implementation? So I would encourage us to think through those things so that we do have something a little bit more pragmatic and less, kind of the 30,000 foot strategy, but more boots on the ground implementation. And I agree that needs to be higher on the prioritization, along with, I think it was 2 slides previously, involving people with lived experience in program development. Nope, it was several slides. So engage individuals with lived experience.
Sorry, I keep.
Anyway, that one. I would encourage us to also kind of, like I said, think through what that means. It's pretty vague, but it should be up there. Thank you.
Okay, so if we can highlight engage individuals with lived experience, all right. We can do further discussions on so far on those 2. I too agree. Thank you, Lisa. Thank you, thank you, Lisa Lee. Thank you, Dr. Dixon, for pointing those areas out. Again, I'm glad that we are having this discussion today so that we can clarify what needs to be one of our, or most of our priorities. So just so that you know, that consider radical changes to recruitment, that came from the interim health committee. And I see that we can revise it to fit the treatment and recovery subcommittee. So, all right, so we'll press on here and go to the next slide. So the final weighted recommendation to date focus on strategies to prevent and treat Black, Indigenous, and people of color at risk for fatal overdoses, and working to expand certifications to increase the workforce for treatment and recovery. So are there any other additional context to add related to any of the recommendations on this slide? Are there any questions about the recommendations? And are we, is there anyone that has a refinement to the recommendation?
Chair Thomas, it looks like Lisa Lee.
Okay, Lisa.
I'm so sorry. I don't mean to talk so much.
No. I want you to talk. This is what this is all about.
Thank you, Chair Thomas. Lisa Lee for the record. So again, I think that these sort of relate back to that recruitment and retention piece, offering specific strategies. So ensuring that we're also offering services to BIPOC communities, because we see evidence of disparities in our overdose data. That certain communities are receiving this overdose prevention training and tools, right? Tools to do the work of preventing overdoses, and then other communities are not. And so that kind of integrates back into the workforce and diversity, and ensuring that we're really saturating all communities to ameliorate opioid-related harms in the state of Nevada. The other piece, the fiscal support for the Nevada Certification Board, the NCB, which I'm a member of that board, we have opened up doula certification as well. It was a legislative item last session. And we did agree to take that on. I think doula certification and doulas being able to bill Medicaid to ensure reproductive health for all women, and I'm sorry, all pregnant and birthing persons. Let me change my language a bit. All pregnant and birthing persons across the state is really huge, and I want to commend Nevada for doing that. But we are struggling. We have one person that is the administrative support for our Nevada Certification Board. And the amount of work is really not reasonable for one person. And then the rest of the board is voluntary. And so I just want to make sure that when we talk about radical strategies, we're also kind of touching on those nuts and bolts in how to do that work. And so fiscal support would be one way that we could prioritize and put our money where our mouths are as far as supporting those efforts to get a diverse workforce and honor reciprocity from folks from other states, and get those frontline workers of community health workers, prevention specialists, peer recovery support specialists, and doulas out there. They are really frontline workers that support our healthcare continuum of services across Nevada. So just wanted to throw that out there, that I think both of these kind of fit with that other piece as strategies. Thank you.
Thank you, Lisa. I see that Dr. Dixon, did you have any recommendations, refinements?
Well, Dr. Dixon, as I'm sitting here thinking about what are some of the barriers to treatment, what concerns me right now is that, one of these days, the president and the governor are going to discontinue the public health emergency, even though they keep extending it. And when that happens, and it's already happening a little bit, people are going to be removed from the Medicaid rolls, and because the expansion, the emergency is over, and the need for everybody to have health insurance lessens. And as a result, we're going to have a bigger problem with barriers, because the company I work for, a whole lot of our patients lost their jobs, lost their insurance, and got put on Medicaid. And we are fairly dependent on Medicaid now for our income. And if they get put off their Medicaid and either have to start paying cash, or because not very many of our patients that have gone back to work jobs that have good insurance. And so I see we have a problem coming down the road, and it's probably not too far off. And I don't know how to put that into all this, if it should be a separate one, but we need to assure that more of our population has access to healthcare in terms of getting it paid for somehow.
So, Dr. Dixon, are you saying that we need a contingency plan on, payments once the federal government pulls out and the state pulls out? How do we continue to service our community?
Yeah, I think that's a good way to put it, a contingency plan
Okay.
Yeah.
Thank you. All right. So is there anything else we're missing? Okay. All right, next slide, please. I'll give you a few minutes to read that. And a number of recommendations were made specifically for youth mental health crisis services and treatment. Our committee looks forward to hearing more presentations and bringing forth our top recommendations at the next SURG meeting in September. There is still time to submit recommendations, and there is also time to refine and combine recommendations. And I think that's what we were just discussing there. So, with that said, does anyone have additional context to add related to any of the recommendations on this particular slide? Are there any questions about the recommendations?
Chair Thomas.
The chair recognizes Lisa Lee.
Thank you, Chair Thomas. Lisa Lee for the record. I'm wondering too, I don't know if this fits within this body or with one of the other subcommittees. So I'm hoping for some feedback on this, but I think we can't really talk about treatment and recovery services without also addressing harm reduction outreach as really kind of being at the forefront of keeping people alive and building those relationships with folks to generate some trust in a system that has often brought harm to folks. And so I really feel like investing in beyond like a mobile crisis team or one of the most teams like true harm reduction outreach to really, be working with folks on safety plans as far as overdose prevention to make sure that we're saturating our communities with drug checking and like make sure that people know that's available, make sure that people know that Good Samaritan laws exist and what those protections are as far as generating calls to 911 or 988. I also think we need to invest in robust outreach teams. This became really, really apparent during our most recent harm reduction summit that was held last week. And, some of our out-of-state folks, Kaylin C. from New York's overdose prevention centers, went out with an outreach team in Southern Nevada into the tunnels. And what struck her was they said that, they were lucky if they could get out there every 2 weeks. And that's a really sad thing, right? Because we should be building these relationships every day doing outreach. And there aren't many organizations that can adequately sustain harm reduction outreach. And I think as a state, we really need to invest in that as well. And I don't see that anywhere here. And I apologize if I was remiss in adding that to the matrix. But I do, and I don't know if it fits in this group either. So apologies if it does not.
That's okay, Lisa. Just hold that thought because we do have item number 7 that we will discuss in a minute. I just want to make sure for this particular slide that you're looking at, if we have any refinements or anything that else is missing here, and we'll get to, points that you were making are valid points, and any additional refinement or anything that we're missing on this particular slide. If not, we can move on to agenda item number 7, consider subject matter experts for future meetings. And next slide, please.
Did that advance it correctly? I'm seeing 7 on my screen, but if I messed something up, let me know. Okay.
No, you have 7. I just wanted to go on to the next one, pending future presentations. Okay. So Um, Please evaluate what you see in front of you. And the presenters and topics listed on this slide include those we've collected from subcommittee members and or outreach to. We would like to fit presentations into the August meeting in order to leave the September meeting open to prioritize our recommendations. And here's a note, there has been some concern that including harm reduction recommendations could crowd out other recommendations related to prevention from the prevention subcommittee recommendations. Other subcommittees also have requested speakers related to harm reduction and have harm reduction specialists as subcommittee members. The three subcommittee chairs met, and we met yesterday, and determined that harm reduction will stay in the prevention subcommittee, but recommendations related to harm reductions will be included in the for further review section when submitted to the full SURG in the final report. In 2023, a subcommittee specific to harm reduction could be created and recommendations could be included in the next report. If there is consensus among the entire search committee about harm reduction strategies such as naloxone distribution, then it could be included as a recommendation in this year's report. So again, Lisa Lee, I appreciate what you shared with us. But some of the questions for prioritizing speakers, what and who would you prioritize based on the initial priority recommendations? What questions are remaining for you before we finalize recommendations? I know there was a lot that I stated there, but did it help? And I'll put that question to Lisa Lee. Does that help? Does that, give you pause to, because I know that harm reduction, just by your statement, means a lot to you. So, and it should mean a lot to all of us. But, when we discussed it among the chairs, we kind of like decided that it would be, and I said yesterday, and I stand corrected, I believe it was Friday, that it would stay in the prevention subcommittee, and we can have another subcommittee in the future that would specifically deal with harm reduction. Does that help?
Chair Thomas, Lisa Leifer, that was music to my ears. As somebody who has been embracing harm reduction since the 1990s, or as my kids would say, the late 1900s. It warms my heart because it used to be such a naughty word. And it wasn't, I mean, there were federal prohibitions on using harm reduction, the words harm reduction in research. And so to hear that it is a high quality problem in Nevada and it is permeated all subcommittees is really wonderful to hear. And I do hope that there is a committee that is dedicated.
Did we lose Lisa?
It does appear she's frozen.
Okay. Okay, and just a note that I was just waiting to see if Lisa was able to come back on. Okay, so hopefully she can still hear us while she's trying to unfreeze herself.
It looks like sorry, Chair Thomas, this is Crystal Duarte, the staff. I just wanted to note that Lisa Lee has left, probably due to internet, and hopefully will join. So we can continue, I believe, discussion of presentation, hearing from other subcommittee members, but would want to hold off on making a decision about who you might hear from until she's able to rejoin, as you
Okay.
don't currently have a quorum.
That sounds great. Dr. Dixon, any questions? I'm not seeing everybody, so I want to make sure that everybody is still engaged here. Steve Shell, do you have any additional information you want to share with us?
Good morning. Not today, Chair Thomas. I just appreciate the discussion today. I think we're definitely on line with what I've been thinking all along. But no, nothing else new to add, so thank you.
All right, thank you.
Well, I
Sure.
just want, I'll say something, Dr. Dixon here. I really am hoping that we can get the Clark County Juvenile Justice Services people to talk, because, you know, one of our problems is a lot of our people that get into trouble with drugs end up in the criminal justice system, and it's kind of sometimes they do well with substance abusers and sometimes they don't. So I'd be curious what they have to say about all these youngsters that get caught with drugs on their person. So.
I agree, Dr. Dixon. I believe we are trying to get the director for Juvie on as a presenter. We are working on that. Any other?
Another thing that kind of fits with juvie is the drug courts, or the specialty courts that specialize in MAT, and we're having actually Judge Bell talk to the psychiatrist next month, or actually September. But we really depend to a great extent on the specialty courts to help our folks stay clean and in treatment.
Would that be every entity in Southern Nevada and Northern Nevada, considering we have specialty courts in Henderson, the North Las Vegas, how could I forget? North Las Vegas, and the regional justice courts there, which I believe the RJC has the biggest for substance abuse, as far as like veterans courts and drug court, things like that. Or is it just in the regional justice courts that deal with drug court?
I don't have any idea how the system is organized. I just know that I have a lot of patients in drug court.
Okay, that's something that we can look into. I'm gonna ask staff to jot that down so that we can look into that, please. And see if we can have a speaker, to come in and give us a clear understanding of what's happening as far as the process for drug court. Did Lisa, was she able to reconnect?
Yes.
All right, thank you. Okay, and thank you, Lisa, for your information that you shared with us before you were frozen out. Did you hear the two um, uh, uh, suggestions by Dr. Dixon?
Thank you, Madam Chair. Yes, I'm sorry that I lost internet connectivity. I was able to hear that. We have a wide variety of treatment courts up here in the north as well, and I know that they're scattered across the state in some rural jurisdictions as well.
And I think that just so that we can have a clear understanding that we should include, if we can get information from Lisa about the north, it would be, I guess, advantageous for our subcommittee to hear from those experts also.
Madam Chair, Kelly Marshall for the record. I just wanted to note that Dr. Kearns noted that she believes there's a MAT court in Clark County as well.
Okay. All right, so we'll just, did we clear up everything there? And I'm gonna ask staff if we did, because I just want to make sure I'm staying on point with them.
Yes,
Okay.
Chair Thomas, I'll just summarize. We did get a question about DHC, a question about Medicaid funding on peer recovery for telehealth services, which, as I heard the committee express, we will be asking DHCFP that question, but I did not hear DHCFP prioritize to present. What I did hear prioritize to present was juvenile justice services and specialty courts. So we would be pursuing presentations in those two areas. Is that accurate?
Right now, I believe so. Am I clear on that, committee members?
Well, I didn't mean to suggest that the other ones' ideas weren't good. I was just saying those are two I'd really like to hear from.
Okay, anyone else? Any committee members, any experts that we missed just now? Because of course, you know, juvie is my priority. So anyone else?
Chair Thomas, Lisa Lee has her hand raised.
Chair recognizes Lisa Lee.
Thank you, Madam Chair. Lisa Lee, for the record, I stick by my two recommendations of Tina Willauer. She is one of the co-founders of the Sobriety Treatment and Recovery Team model that we are looking to implement in Washoe County as part of the Family First Prevention Services Act. So specifically piloting with our prenatal substance exposure cohort that are screened into child welfare. Tina is a wealth of information. It is a model that embeds peer recovery support specialists within the child welfare model, thus providing employment opportunities and some job equity there, as well as providing way better services to the people that we serve. And then I also stick by my recommendation to have Kaylin C. come and present. I did attend her presentations at the Harm Reduction Summit, and I found it absolutely mind-blowing. I would love for this body and maybe possibly the SURG as a whole to receive that that education around what overdose prevention centers look like versus what people may think they look like. It's pretty incredible. Thank you.
Okay, great. All right, and I know staff has included that in the notes. Okay, anyone else? Okay, we'll move on to request to present. We have been given guidance from Attorney General to fairly and consistently apply a vetting process to for speakers. Some speakers that have contacted staff have been referred to DHHS website where funding opportunities are listed. For transparency, we wanted to bring these to the subcommittee to see if anyone had questions or would like presentations. Dr. Posen works with veterans applying an evidence-informed treatment for PTSD. He was referred to DHS website for funding opportunities. Dr. Corona has provided a variety of treatment models throughout Las Vegas and has experience working in correctional facilities in Washoe County as well. He has perspectives on the gaps that we have in our state regarding treatment and how to address them. Dr. Hines has promising research on treatment. Peers Pharmaceuticals was referred to DHHS website for funding opportunities. So next slide, please. Any questions? I'm sorry. Any questions regarding those requested presenters? Okay, I cannot see anyone. Staff, if you see anyone, let me know.
No one has indicated they have a question.
Okay. Next slide, please. Public comment. All right, this is our second opportunity for public comment. Public comment will be received in person via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. And any hands raised for the Zoom? In the Zoom?
I do not see any hands raised.
And do we have anyone on the phone?
I don't see or hear anybody on the phone indicating they'd like to make public comment.
Okay, so we'll move now to agenda number 9, which is adjournment. And it was, I think it was a very informative meeting today. I appreciate all your participation, and I look forward to our next meeting. And staff, if you could just give us some dates, because I believe we have some kind of confusion when it comes to our next subcommittee meeting for treatment and recovery.
Yes, your meeting is August 12th. And let me just check the time.
Crystal, I have it as 10:30 to 12.
That's correct.
Okay, sounds good. All right, we'll see each and every one of you next meeting on August 12th at 10:30. Thank you again for participating, and I appreciate all the input that we got today. I think it's helpful, and we're on point for getting this completed for, I believe, our big SURG meeting in October. All right, thank you all. Have a great week.
Thank you. Bye.
Bye-bye.